Welcome everybody, 2nd of October, and we're delighted to welcome you to the 20th UCD COVID seminar series. Lovely to see so many familiar names and faces back again. We're joined by some new people, so that's lovely also. I'm delighted to co-host the session with my colleague, Dr. Blonid Gavin, Paul Harkin from UCD, and it's also co-hosted by the College of Psychiatry Ireland. But a particular pleasure today is, unfortunately, I have to drop out halfway through, and I'm delighted that my colleague, Dr. Anne Jeffers, is going to provide the discussion at the end and moderate it. And many of you know is a general adult psychiatrist. She's the national clinical lead for the self-harm program, and she's also head of policy at the College of Psychiatrists. And I think the topic of today's conversation is very important one, and I think Anne will raise a lot of very interesting discussions. So if I could just move on then to introduce our speaker today, I'm delighted to introduce Professor Dominic Sisti, who is professor in the Department of Medical Ethics and Health Policy in the University of Pennsylvania, but he also has affiliative roles with the Department of Psychiatry and Philosophy, and really would contribute significantly to medical student teaching around ethics, which obviously is so important in our own area of psychiatry. Dominic is very well published both in the academic and in the popular press, and the sorts of research and papers that he's written about relate to the ethics, to policy, covering areas such as the diagnostic classification of psychiatric illness in our various classification systems, social media, and mental health care and delivery. Dominic is the director of the Scattergood program for the Applied Ethics and Behaviour Health Care. And his topic today is the clinical and ethical challenges with regard to individuals in an inpatient psychiatry setting when they refuse to comply or be able to adhere to the COVID testing, quarantining, or social distancing. So Dominic, thank you very much, and I'm looking forward to the talk.
Thank you so much, Fiona. I appreciate that kind introduction, and I'm very honored and privileged to be with you all today. I come to you from Ocean City, New Jersey, where I am taking a couple of weeks with my family to try to kind of brace for the winter in isolation back home in Philadelphia. So I hope so the internet is a little bit spotty here. I just hope it stays with us. I've got a few acknowledgements before I start. Dr. Mark Russ, my co-author on the paper we'll be discussing, is the vice chair of clinical programs and is a professor of psychiatry at Cornell. And likewise, my other co-author was Dr. Phil Wilner, who is the CEO of the New York Presbyterian Behavioral Health Center up in Westchester, New York, and is a professor again at Cornell. A lot of my research is supported by the Thomas Scattergood Behavioral Health Foundation, which is a small foundation in Philadelphia. And so today I'd like to just go over this paper with you all and discuss some of the ethical aspects of working with, treating, and caring for individuals who have mental illness and are refusing COVID testing, as well as isolation, social distancing, mask wearing, all of the precautions that are really necessary to forestall or prevent the spread of this virus through a inpatient psychiatric hospital. And so to do that, I'll just go through the case we present in the paper. Then I'll go through the ethics workup on that case, describe policy and regulatory issues that haven't been fully clarified yet on how to handle these types of situations, and then offer a few recommendations on all of this. And then we'll have hopefully plenty of time for discussion. So here's the case. If you haven't had a chance to read the paper, I'll just go ahead and read this case out loud. The highlights are there on the right of the slide. This case involves, and by the way, this is a composite case. It's not an actual case, but it is based on several actual cases. Some of these this case may sound familiar to many of you because it's not real, and it is not uncommon, as I'm beginning to learn from my colleagues across the country. A 26-year-old man with a history of schizophrenia is brought to the emergency room by police from a men's shelter where there has been an outbreak of COVID-19. He is behaving bizarrely over the course of several days, building a barricade around his bed and loudly threatening peers and staff who approach him. He is disheveled, observed talking to himself, and engages in odd movements reminiscent of martial arts. On arrival to the emergency room, the patient does not permit vital sign measurement, physical exam, or routine lab testing. He does not want anyone touching him or sticking things into him. He does not make eye contact and continues an incoherent banter, intermittently assuming a menacing posture when approached. The patient is maintained in a single room in the emergency room for several days, awaiting medical clearance in preparation for involuntary admission to a psychiatric hospital. Attempts to engage him and explain the need for medical evaluation, including COVID-19 testing, are unsuccessful. Antipsychotic medications are likewise refused. The patient is encouraged to wear a mask and remain in his room because of a concern that he was exposed to individuals with COVID-19 at his shelter and may himself be infected. He does not comply. He is repeatedly verbally redirected to his room. All staff in the area wear full personal protective equipment, and visitors are not permitted in the area. The patient does not appear to be exhibiting common symptoms of COVID-19, no sweating, cough, or shortness of breath. The patient is admitted to a general psych unit, given a single room, and asked to remain there pending COVID-19 testing and encouraged to wear a mask. The patient arrives on the unit and refuses to remain in his room or wear a mask. Using a variety of techniques, staff attempt to engage the patient, but are unsuccessful. The patient wanders freely about the unit. So, does this case sound familiar? In medical ethics, we typically appeal to sets of principles to begin to unpack difficult ethics cases, as the one I just described. And let me just go back here, sorry. In normal times, this would be a difficult case to handle as it is, but we're not in normal times. In normal times, we would say, okay, this is an issue where we're trying to find a middle ground between respecting this patient's autonomy, or if he's incapacitated, his respecting persons, just basically respecting him as a human being, and the principle of beneficence, which entails doing what's good for the patient and thinking about the patient's best interest. So in normal times, when a patient refuses treatment that would be very beneficial to them, we sort of have to think about at what point does it make sense to begin the process of leveraging, or I don't like to use the word coercing, but using compassionate coercion, potentially. And depending on the patient's capacity will determine which direction we go, whether we head up more towards respect for autonomy or if we focus more on beneficence. In cases where a person is intermittently capacitated, or we have evidence of what their desires would be in a certain particular situation, we can infer from those values using the standard of substituted judgment to try to enact whatever that patient would want. So if they have a psychiatric advance directive, for example, that says, I would want X, I would want Y, I wouldn't want X, I wouldn't want Y, we would follow that. And that would be, a stand-in for their autonomy. When they're fully incapacitated and we don't really have a whole lot of idea what they would want, then we shift over to the best interest standard. And this is the typical calculation that happens on a daily basis in psychiatric hospitals, crisis centers, and frankly, any hospital setting where individuals may have compromised capacity. This is the kind of trade-off, the kind of balancing act that is not uncommon and happens all the time during normal times. However, we're not in normal times. We are in a completely abnormal time where the issue of capacity the issue of best interest, these things get complicated. And just before I get into that, the next slide to show you the complications, I just want to be sure that it's clear that when a person is determined to have capacity or incapacity, that's not a statement about their global capacity. It's not a statement that pertains to everything that the person can or can't do. It's very specific to specific decisions. So even in the US, for folks who are involuntarily committed, they retain the right to make medical decisions and have their capacity evaluated for basically every major decision. So it's important just to keep that in mind, that capacity is not global, it is particular. And it's also really, I think, important to remember that any psychiatric diagnosis, even something like schizophrenia or other serious mental illnesses, just the diagnosis itself does not automatically entail incapacity. It may give us a clue that we need to probe a bit, but simply the diagnosis itself doesn't provide us much in the way of knowledge about capacity. A person with schizophrenia can have capacity to make certain choices, even when they are partially psychotic. I won't say floridly, like in this case, but it's important that we remember that capacity is not as straightforward as it sounds. It requires evaluation for each decision, and it's not tethered to a specific diagnosis. So in this case, as I mentioned, we're not in normal times, and there are a number of things that this patient is refusing. They are refusing the exam in the emergency department. They're refusing medication, COVID-19 testing, quarantine or isolation, social distancing, mask wearing. How do we think about whether we should respect these refusals, or whether we should begin to engage in a process that leverages or nudges or even forces the individual to begin to, and I'll use the word comply, because I think comply is okay in this context, comply with public health and institutional policies. And so in our reality today, the question of whether and how to engage in involuntary treatment turns from a dilemma into a quadrilemma, where there are 4 principles in tension: respect for autonomy, beneficence as before, but also, given the fact that this is a highly contagious, deadly disease, COVID, a virus, we have to also account for others in a way that we don't really have to account for in a normal situation. I mean, there are going to be implications for others in normal times, but not as pronounced. So we need to think of other principles in tandem with these 2 traditional principles. And so in the paper, we mentioned justice and solidarity. These are principles that entail understanding, knowing, and mitigating risk to others, other patients on the unit, staff members, and anyone else that may happen to be involved in the care or interaction with this particular patient. We need to have a sense of duty to those folks, and that's not easy for clinicians who are trained to advocate for their own patient and not anyone else, right? Not to think globally so much, but rather to think individually. We also need to think in terms of solidarity, that we all really need to do our part to forestall the spread of this illness. So in this particular case, we know that respect for autonomy is not going to be a primary principle, because of, one, the patient appears to is incapacitated, and we don't have any evidence of prior wishes, at least in the way that we produced the composite case. Beneficence, of course, we'll want to always try to ensure by thinking about what is in the patient's best interest and providing that. And then justice and fairness provide safety for all of those individuals, staff members, and others who are working in the unit, other patients, et cetera. And then, of course, doing one's part, as I mentioned, is part of solidarity, which basically means we need to expect others to do their part. And if they don't, we have to figure out ways to get them to do their part, especially in a closed institutional environment. We also have a few other problems on our hands with this particular case. The quadrilemma is constrained by time, so we've really got to figure this thing out rather quickly. And he's already been in the ER for a couple of days, not a great place to be. So we want to move quickly to figure out whether this individual has COVID, whether he is a asymptomatic spreader at the moment. In the meantime, we want to be sure we immediately keep him in isolation and hopefully stabilize his psychiatric symptoms while doing all of this, such that we could potentially get him to a place of capacity where we can have a conversation with him about being swabbed and tested for COVID. This all has to happen relatively quickly, and when you don't have clear guidance on how to do that, it can get, that can become a very difficult situation for staff. So, the ideal way to approach a case like this, as you all know, is by engaging in a process of shared decision-making and beginning to try to attempt to get the patient to be involved in their treatment. Of course, when a patient has florid psychosis, shared decision-making will fail most of the time. And so, what do we have to do then? Well, we have to begin to consider treatment over objection. And in considering that, we have to think about whether and if the modality that we're considering is even possible. Do we have the resources we need to make to essentially restrain the person or medicate the person such that we can swab them and test them? There are serious potential harms in this kind of involuntary treatment, and so you need to be 100% sure that the staff knows and is well trained in how to restrain a person in this situation. Moreover, we want to find out if the staff are willing to, because this is as you all know, this is a very difficult thing for folks to do. It's traumatic for staff. It's traumatic, obviously, for patients. Sometimes it's just, the harms of just the process itself may outweigh the benefits. In this case, I would say it doesn't, but we need to be sure that the staff understand the situation and how to move forward. They need to be trained on how to restrain without harm and be willing and able to do so. If the patient has a phobia of the swab, if it's as it sounds in the case to be something that he's completely objecting to, is the sticking of something into his person, then potentially we could wait and watch while this gentleman is in isolation. But if he's not willing to isolate, then you really need to swab and get that test done. If he is willing to isolate, you might be able to play this out for a few more days. Maybe, if you can keep him in quarantine or in isolation for 2 weeks, that would be fine too. Then the question, emerges, well, is that more harmful than just a quick sort of forced swab? Would it be worse for him as a person with SMI and psychosis who's refusing antipsychotic medications to be isolated for that long? Would that create progressive symptoms and worsen his condition? And instead, we should swab and allow him to be, if he's COVID negative, to be a bit freer. That might be, that trade-off might be worth it. But overall, no matter what we do, the point is we have to figure out what the course is that will cause the least amount of trauma. So in ethics, a lot of times we like to say there's no really good option here. In ethics, it's just trying to pick the least bad option. And I think, this is one of those cases where there's no positive outcome that we're really looking for. It's just we're trying to mitigate or minimize negative outcomes or harms. And that's, done through a proportionality kind of calculation. And I just broke the, sort of the upsides and the downsides down here to try to illustrate that in terms of the forced treatment. The patient will experience trauma and potentially exacerbation of SMI. The family, caregivers, et cetera, may feel trauma, guilt, feelings of helplessness, and the staff may experience what's called moral distress. The idea that they're compromising their own ethical values in the service of the public health guidelines. Again, this is a difficult needle to thread, because in normal times, clinicians are obligated to care for their patients and only their patients, and ensure that their patients are not harmed without good reason. In terms of medical care, there are going to be certain things that will cause harm, but at a greater benefit. In this case, it's not clear for, I think, some staff that calculation makes sense. So I think it's really important that staff are educated on this type of thinking. The positive outcomes, of course, not really positive, but less negative outcomes would be that the patient is safe, right? And if they are COVID positive, that their symptoms will be managed appropriately. Again, key upsides for families: safety, staff safety, and the general public safety. So those three safety upsides are things that we normally don't have to really consider, other than in cases where a patient maybe is dangerous or presents as a danger to themselves or others. And that would be in cases of suicidality or homicidality. So those are very different, I think, than the safety concerns that are related to COVID symptoms, which can be spread so easily by an asymptomatic carrier. And so we really need to be super careful with this individual, but at the same time, try to avoid exacerbating his symptoms. And so when we begin to start thinking about involuntary or non-voluntary or compulsory treatment, we can think of various interventions as kind of points on a continuum of what's called leverage in the literature. And here I'm just referencing a paper by George Zmuckler and Paul Applebaum, in which they lay out a very, I think, useful hierarchy of treatment pressures, as they call them. And these begin with persuasion and move up to interpersonal leverage, inducements, threats, and compulsory treatment. Each of these points on this continuum represents a step up in terms of the pressure, as well as a step up in terms of the need for your ethical justification to be really strong, right? So you can't go about providing compulsory treatment with a weak ethical justification, right? You need a very strong, even legally sound approach to compulsory treatment. On the other hand, persuasion is something that we all, I think, do. All clinicians at times will try to persuade their patient to do what's in the patient's best interest. And that often requires the patient has a degree of capacity to be persuaded. This particular patient isn't really persuadable. Interpersonal leverage refers to the idea that you'll use your relationship with the patient as a way to motivate the patient. So if the patient has a long-term relationship with you as a clinician, you could say, well, look, this is really important that you say take your medication, or you get this test, or you agree to isolate. It's really important for you, and it's really important for our relationship that you do this. It may impact our relationship. We may not be able to continue, et cetera. That's interpersonal leverage. It's also, I like to call it the sort of guilt strategy. Coming from an Italian Catholic family, I know that strategy too well, and it works. So I would say interpersonal leverage would work. However, again, you need a degree of capacity with the patient. Likewise with inducements, where you will reward the patient for doing something that they don't really want to do, sometimes requires capacity. It may not. So in cases like this, if you could figure out a way to engage the patient on something that they would value, that can be used as an inducement to get them to, and again, I'll use the word comply, to comply with the public health guidelines. Then we start to get into more dicey types of leverage. So threats are a form of leverage that are often used, and threats don't necessarily have to mean holding a gun to someone's head or telling them that they're going to be hurt or something if they don't do what they're told. Threats can simply mean the offering of unwelcome knowledge. For example, saying, you know, if you're not able to comply, and this is not related to this particular case, but in other cases, if you're not able to comply with the medication or the testing or whatever treatment regimen we think is in your best interest, it may be the case that you can't go home for a while. It may be the case that you might not be able to see your kids for a while. And so those are not necessarily threats in the sense of, you know, as I mentioned before, very obvious threats. But that is, I mean, it is the presentation of factual information in a way that is designed to motivate the person to begin to comply or to begin to listen, at least, and engage. So sometimes threats are used. In this case, we're at a place, I think, where we're all the way up to the top of the hierarchy, where compulsory treatment is justifiable. And the strength of that ethical justification comes from really the two additional nodes on the ethics workup, which is that there's serious public health and safety issues at stake, and there's, you know, any number of individuals that will be affected by by the patient's decision to refuse testing and isolation. So that, I think, is, you know, takes us well above the bar, I think, for kind of leveraging a person into getting COVID testing and isolating if necessary. Okay, so big question then is, in reality, involuntary COVID-19 testing legal, and is it ethical in reality? I need this. It's somewhat unclear in New York State if COVID testing is covered under what's on the books for involuntary mental health treatment laws. State regulators that encountered this case in the Cornell Hospital, or encountered a similar case in the Cornell Hospital, were a little bit hesitant about testing over objection. They weren't completely sure that that testing over objection would be legal, and whether or not it's ethical. And so there was a lot of concern that was raised by, in particular, one state legislator who raised the alarm bells about forced testing in the hospital. Now, you have to also remember, and I don't know if this is an American artifact or if this is a global thing. Excuse me a second. Give this to Nadia, and go in there, please. Sorry, my kids are coming to visit. Where was I? State regulators. Oh, I have to just kind of make this point, which is that, you know, here in America, in the United States, we're in a situation where mask wearing is a partisan issue. So, you know, the implication, the effect and impact of politics here is not to, you know, something to be glossed over. I mean, this is a real thing where, you know, patient rights, for example, are or arguments for patient rights are somewhat camouflaged, or arguments for political arguments or political positions are often camouflaged in, you know, patient rights type arguments. And so we have to be careful that we're not kind of in this partisan morass of anything really goes based on what you believe to be true. And that's the sad state of affairs that we find ourselves in. And the regulations, to be fair, the regulations do emphasize immediate physical danger. And so it's unclear whether infectious disease actually counts, because in terms of immediate physical danger, the regulations are really, I think, referring to physical harm, assault, battery, things like this by patients in inpatient units, and not necessarily viral transmission. And so we've got to figure out whether and how those regulations can be adjusted. But there is historic and contemporary, parallels in general health law. And those are with regard to tuberculosis. And of course, in New York, we had Mary Mallon, who, AKA Typhoid Mary, who spent years on an island in the East River in quarantine because, she had refused to stop working and cooking. And so those laws have been on the books for, a century now, and have now become particularly important in the case of COVID, because now I can think back and look back at those and say, well, look, in those types of cases, we would want to certainly commit individuals to isolation, but they must be appropriately treated and given appropriate accommodations. A few cases in New York pertain to this issue, and several individuals who were in psychiatric hospitals were sent to quarantine. However, they weren't sent to a hospital, they were sent to jail, another American solution to a problem, right? Send people to jail who are mentally ill. Makes very little sense, and we obviously can't be even considering that now. But back then, in the early part of the 20th century, and even in some recent cases that I read, individuals who were non-compliant in inpatient settings regarding TB were in fact quarantined away in a jail. So that's not going to be something we want to do. So, so we need some further clarifications about the rules regarding COVID-19 testing over objection in the context of SMI. And I think those rules really need to reflect patient-centered, recovery-directed care, but they also need to be balanced against the public health risks. So these new regulations need to kind of encapsulate the quadrilemma that I described, and how to navigate that by understanding the facts on the ground first. So it's going to require regular review of the epidemiology of the location. So these regulations, so this is really kind of a moving target. As the spread of the disease or of the virus either waxes or wanes, that will affect the ethical calculations that we're going to be making regarding these trade-offs between patient autonomy, COVID risk, and beneficence, justice, and solidarity. Some weeks we'll have to make safety the first priority and not even get into sort of debates about isolation. If there's a surge happening in the nearby community, or if there's a serious spread happening in the unit itself, some weeks will be patient first. In times when the virus is not spreading as quickly as it once was in the community, or if the unit or the institution is COVID free, then you can begin to think about beneficence and autonomy more so than the public health guidelines, and prioritize the traditional principles of respect for autonomy and beneficence. And then most weeks, I think, will be somewhere in between. I don't know what the frequency of review should be, but the point here is simply to say that the ethical calculations are connected and tethered to the epidemiology. And so that needs to be something that's reviewed regularly to see if your calculation is still appropriate. As I alluded to earlier, education for and clear communication with clinical staff and attendings and docs and nurses really needs to be, clear about expectations for potentially having to forcibly test or isolate an individual. But those, that education, that communication needs to be super sensitive to the moral distress and trauma that is often experienced by clinicians when they have to do hard things like restrain a patient. And so I recommend that there be regular ethics rounds or case discussions to allow staff to at least kind of vent and reach have a community of support when they have experienced the distress or even the trauma of engaging in a restraint process with a patient. In the paper, we also just quickly allude to this other recommendation, but this kind of pertains to another project I'm working on, which is the design of psychiatric hospitals that are humane and recovery oriented, now also really need to be designed to be quickly convertible for infection prevention in outbreaks. That means being able to have patients in single rooms at all times, and having the space to continue to provide alternatives or adaptations to things like group therapies or milieu-based therapies that are so central in psychiatric hospitals, that those can continue in some form, maybe not fully in person at times, maybe there'd be sort of a closed circuit version of it for patients in their rooms, or maybe they can be smaller groups spread out or done outside, various kind of creative ways to allow patients and clinicians to engage in person, and while also mitigating the risk of COVID spread. So these are just a few of the recommendations that we mentioned in the paper. And I'd be certainly happy and open to hearing other views on this. I'm just looking over to see what time it is. I'm sorry. 10. Okay. So I'm going to just wrap up now so that we have time for conversation.
That's really great. Dominic, thank you very much for a fascinating presentation. And I think you've really given us plenty of food for thought. And I'd invite the audience, if you have a question for Dominic or even a comment on your experiences over the last number of months in this area, just put it into the chat. If you want to put your question in, put it in, or if you just want to say you have a question and we'll call you in. Fiona, as she said, left, but before she left, she very kindly put in a few questions herself. And she made a very interesting point that while this case that you presented clearly was complicated by mental illness, what advice would you have had if he hadn't had a mental illness, but was still refusing to cooperate, if he had arrived in the ED with another problem? What would you
so those are really tough cases. That's actually that was another angle I was going to try to address, is like, what's the difference between this gentleman and just a masked protester out on the street in New York or wherever, in Pennsylvania? Mental illnesses. So if he was not if he didn't have a mental illness and wasn't incapacitated, you're kind of stuck. You have to, at least in the US, you've got to basically allow him to leave. Now, if he's going to stay in the ED, if he's got to stay in the ED or in the hospital, then you can begin the process of going to a judge or getting a judicial review of the case to begin the process of either swabbing or isolating the patient. But at the very least, an individual who's not mentally ill but is non-compliant with testing, for example, will be isolated. There's no question about that. They will not be allowed out of their room. In fact, I know people who were totally compliant, wanted to be cooperative, et cetera, and were locked in their room for many months. So as some of you probably know as well. So in cases where a person's being like mask resistant or testing resistant, if they need to be in the hospital, they're going to be isolated. And eventually, I think they'll come around to being tested. If that's the only way, maybe they can get out of their room to take a walk. And so I'm okay with that. That to me is a perfectly appropriate thing to do. Again, you want to do it sensitively. You might want to unpack why they're so resistant. You might want to say, well, what is it about this test that you feel so strongly about that you don't want? Or why aren't you wearing a mask? And, they might say, well, I heard that it's not that bad, or I heard that that masks are not helpful, or I heard that, it's all a Democratic hoax. In those cases, lots of education, I think is appropriate. But if they're still stalwart on not cooperating, then you take some drastic measures, like in the TB cases, where there is precedent and case law.
Right. And I suppose at the moment we don't have treatments, so we're not talking about treating people who are mentally ill any differently from people who are not. But one question Jerry Rafferty has put in: could it be extrapolated to a vaccine if it were found? And
yeah, that's a great question, and I think the answer is no, actually, on that. Unfortunately, forcing vaccination would, I think, have a blowback effect that would actually hurt the public health more. So if word gets out that they're forcing vaccinations on people, there's going to be a lot of vaccine skepticism and resistance. So for me, that is a bridge too far, not because it's wrong in the moment, but because of the broader public health ramifications that kind of coercion would have, at least in our society, in the United States.
Right. And the other question Fiona had, as regards the ED, it sounds as if it would be a good idea to have a leaflet or explanatory notes for ED staff in working with somebody with a mental illness who's COVID positive. And I think some of the services around Ireland have already developed something like that, but would you have a comment on that?
Yeah, that would be, I think, appropriate. I think having an ethics committee prepared and ready for these cases is also an important thing. I think a leaflet's helpful, but I think having an actual ethics consultant around to help with these types of cases is better, so that ED staff can just call a person on the committee, ask for a consultation, and get some guidance. But yeah, leaflets, ethics committee, and constant education about this. Again, being clear that the rules are slightly different right now, right? That autonomy does not trump all other principles during a public health catastrophe. And so we've got to really begin the process of re-educating people around medical ethics in a certain way, which is to say, it's time to think about public health, solidarity, and justice.
Yeah. All right. And it's interesting here in Ireland, and I'm sure in the States as well, there was great cooperation between the Department of Health, the health services, the clinicians, and our regulator, the Mental Health Commission, in developing a framework to try to reduce risk. But interesting, and you comment in your paper on this, that there was no guidance on how to manage where the patient refuses. So were you surprised to find that it seems to have happened internationally? Yeah. that area.
I think the overarching theme of what you're describing is that these settings have been overlooked, and overlooked for years, right? In terms of, at least in the United States, in terms of the importance the important role they play in a comprehensive mental health care system, which we don't have, to be honest. But also the importance they play in infection control. And, we were very, I'd say, preoccupied, I shouldn't use the word preoccupied, but we were very laser focused on ethical challenges related to triage of things like ventilators. Like, we spent weeks and months in the early part of this debating that, you know, who should get a ventilator, right? Which is a super important question. But meanwhile, folks in nursing homes were dying by the dozens because we hadn't thought about how to effectively manage populations in congregate settings like nursing homes and psychiatric facilities. And so I'm not surprised there was no guidance on that. It's sort of like, these are the folks and these are the places that just seem to slip everyone's mind. And that's how it's always, that seems like it's always been that way for people with serious mental illness. Again, they're forgotten. And you know, that to me is another point of justice here, which is to say, you know, we have to attend to these people appropriately and not forget about them the way we have been. And so I'd say, we need to recalibrate our expectations and our ethics around the public health in tandem with trying to focus on the least well-off individuals who are in psychiatric settings, individuals who are incarcerated. You know, the United States has a mass incarceration crisis, I would call it. It's a disaster. There's, you know, close to the population of Chicago behind bars in the United States. And 30 to 40% of those individuals have a serious mental illness. They're forgotten, you know, and when COVID strikes a prison or a jail, it's pretty much like wildfire. And it hasn't really affected the policy making at all. And I think, you know, we're going to get to a place of reckoning. And I think we're here where we've got to begin to really consider these folks. I mean, even from a self-interested perspective, right? Even if you don't think these individuals are worthy of anything or human, from a self-interested perspective, you would want to control infection spread in these places so they don't turn into hotspots, right, for the community.
Certainly. And I think here, I mean, we've actually had a very low rate, both in our mental health institutions and also in the prisons. So, you know, I think the frameworks they worked, but the protecting the rights of the patients isn't something that has been addressed as such. Just a few more questions. Kate Irvin has, if treating the mental illness meant that compliance with COVID-19 was improved, does it mean that involuntary treatment is warranted?
I think.
Yeah.
I'm sorry, Anne. Was there more to that, Anne?
No, that's it.
Okay. Yeah, I think so. And I would say that the two things are parallel. As you're trying to get the person to get tested and become kind of aware of the need for isolation, et cetera, you can also try to coax them into medication and treatment for their psychiatric symptoms. And I think, you know, if it's to the point where you know the conversation around isolation and testing fails, then you can begin to trigger these involuntary treatment processes around, say, stabilizing psychosis or bringing the person back from psychosis so that they maybe have the capacity again to have an engaging conversation about COVID. So yes, I think it is appropriate.
Okay. And then your reference to the Schmuckler paper and the coercive shadow that many of our service users complain about, that, you know, they know that as soon as they're in an approved center, they have to stick with the rules. This would be even outside of COVID. We don't have, our capacity legislation here is quite outdated. We have a new act that hasn't been introduced. And we rarely have the use of advanced healthcare directives. So when we're at this point, have you some suggestions or recommendations for us on how we can get the balance? Now, our Mental Health Commission have produced a report that has shown about 40% of our approved centres use seclusion, so 60% don't. And about 80% of the units will use forced medication, and therefore 20% don't. But would you have advice for us on how to introduce that better approach to recognizing and protecting patients' rights?
I mean, I think, you know, the coercive shadow issue is a twofold problem. It's one, about the misuse of leverage and coercion at times, and two, it's about transparency of the use of that leverage. And so to me, that it's always, I think, preferable to figure out ways to open up and be honest about the reasons for the coercion with staff and with service users and others who may be able to, you know, if a person has capacity and can engage in a conversation about the regulations, you can educate them on the reasons for these rules, and hopefully that will help. Now, you know, so I think that's the first step, is trying to get the communication right with everyone, and that isn't something that can just be done with a leaflet or a law, or just, it has to be constantly discussed and integrated into the culture of the institution. And it really depends on the institutional culture at the moment, how you go about doing that. But it's really, I think, critical that these very difficult conversations happen on a regular basis, and that clinical teams are completely open about what it is they have to do and what they're doing, so that they can, one, support each other when things are really difficult, but also learn from each other. And likewise, service users and patients should also have a venue to have a conversation and discuss the issues. And family members, all stakeholders need to be involved in this. And so that would maybe bring harmony a bit to the various institutions across Ireland and the world, in terms of an approach. It's going to be different, again, for every location, how stringent the rules have to be based on, again, the epidemiology. But the basic principles, I think, can be generalizable. And so if you can generalize across institutions on principles, but then recognize that specificities and applications will be context dependent, I think that's the start.
Mm-hmm. Right. We have another question here, and you've spoken about it a little bit there already. How can we educate people to follow guidelines like mask wearing, social distancing, and so on, if they are following opinions from fringe doctors, nurses, and researchers, or senior politicians, or whatever? Have you any advice on that?
I wish I knew the answer to that, to be honest. Look, I don't know what it's like there, but here it's almost impossible to get through to someone now. It's been a brainwashing process that's been incredibly disturbing to witness. And now we're at a place where people actually think there are two sides to the debate around mask wearing. It's completely beyond anything I've ever seen in my life here, in terms of the polarization and the irrational polarization and refusal of some folks to actually just look at facts. So when you're kind of stuck with a situation where you're in epistemic anarchy, which is kind of where we are in the United States, I don't know how one educates well. I think the public health services are trying their best to get the word out and to be clear, but as you say, politicians, our own president has created a morass of doubt, and in my opinion, has done immense harm to the process here in the United States of trying to control this pandemic and the spread of the virus. He's done way more harm than good. And in terms of the education of his base, that is something I just don't know how to do. I mean, it's, if you have any ideas, let us know, because there's a population of people who are completely stuck on this idea that it's not that bad, or masks don't work, and that there's no changing their mind.
I mean, we're at that now. For the first 2 months, we seem to be very good. Everybody was prepared to go with public health, but then it's just been very difficult in the last few months. Okay, just as a final question, talking about the rights of patients, there were two other areas here in Ireland, and I'm sure it's the same in the States, where the rights were compromised since COVID. The first, we had emergency legislation introduced that just changed how detention was reviewed. Normally people would have a 3-person tribunal that they would meet face to face. This was changed to a teleconference. I'm not sure if it's actually been used, but the law also stated, if necessary, 1 person could make a decision on reviewing the detention. So that was one thing. And the other, visitors have been prevented, and this affects vulnerable patients both in acute hospital and in mental illness. So both of those have affected the advocacy for patients. Have you a comment on those?
Absolutely. And I'm glad you brought that up. You mentioned visiting guidelines and restrictions. This is something that's been a worry of mine since day one, because for individuals with disabilities, whether they're physical disabilities, intellectual, cognitive, mental health issues, or dementia, these are individuals who rely on family members, caregivers, and others, friends, to survive. These are not visitors. These are people who should be thought of as allied healthcare professionals. And my opinion is that hospitals any hospital, but particularly hospitals that are, or congregate living settings that are for folks with disabilities, need to figure out ways to allow caregivers to be with their wards, their patients, their friends, their family members, their loved ones. I just had a friend, an elderly friend, die, not of COVID, but of cancer, and she was able to have 1 person come with her. That took work. That actually took pulling some serious strings to get this 1 person with my elderly friend in hospice, in an inpatient hospice, and they were not allowed out of the room for several days. And that's okay. At least they were together. I had another friend who was on bed rest for over 2 months, not allowed to leave the room, not allowed to see her son or her husband. The mental health implications and outcomes from those kinds of policies are profound. These are policies that are sensible in the short-term sense, but they're not in a long-term sense. And so I know that some hospitals are beginning to realize this and revise their policies, but there's got to be ways to allow folks to spend time with their loved ones. Staff are coming and going every day. They're not living at the hospitals. Why shouldn't patients have the ability or to be with their caregivers, right? The other piece to this that it doesn't really make a whole lot of sense, that folks haven't realized this, but these caregivers are actually doing the work of healthcare providers, allowing the staff to be freed up to take care of other people. So it's really like, it makes a lot of sense to figure out ways to get these folks in as free labor, if anything. And so I still haven't figured out why, this policy, these sort of draconian visitor policies still exist now that we have 6 or 7 or 8 months now of experience with the virus. And at least in the United States, we do have plenty of PPE so that folks can wear, protective equipment. There needs to be a loosening of those regulations, in my opinion.
Right. Well, thank you very much, Dominic. We could keep talking, I think, for another hour. But on behalf of the audience and everyone, I'd like to thank you for really fantastic presentation and discussion. And I think, Paul, you're now going to put up a slide just to remind everybody about next week. session, which is on the experience of working with COVID-19 in an acute inpatient psychiatric ward, and then also to remind people about the conference that has been organised for the 16th of October, Occupation Stress, Burnout Among Healthcare Workers, which is of interest to everybody. So thanks very much to everyone. And we, Dominic, we're going into another room, and thank you to everybody else. Okay.